Dr. Gajre has also been a principal investigator in 3 international trials and 5 national trials, along with being a guest lecturer in more than 30 seminars and more than 60 to 70 poster presentations in international and national conferences. And also, no, the last but not the least, she has 56 publications for credit, which includes 22 international and 34 national, and also has authored chapters in 6 books. And I'm sure today's discussion on learning disorder mimics, led by Dr. MonaGajre, will be as interesting as the last fourth edition of Brainmantra. Once again, welcome, ma'am, and over to you.
Yeah. Thank you for that kind introduction. It's always wonderful to be back, though online. And so, what we will be talking today is on learning disorders mimic. I specifically thought that just like autism, we will do part one and part two, because so autism also, though it is a neurodevelopmental condition, it is more or less from the behavior of the child, the eye contact, and there is so much of awareness of autism globally, uh, the speech, etc. So some cues are definitely there for the parents to pick up. Learning problems occur only as the child grows older. It is noticed not mostly by the parents, but often by the school teacher. And there is so much of layers to what could be the reason for academic delay in children, that I thought it is better that we have this in two parts rather than one. So last time we discussed the way this will be is last time we discussed on learning disorders specifically. Today it will be again a little bit of revision of last time's slides, but also a lot of cases which can come as LD learning disorders mimic, or they are also often associated with learning disorders. So, it is either way. So, and as we discussed, most of the neurodevelopmental conditions can have a presentation. There is almost always a comorbidity present, right? They never come alone. They come with a partner or a friend and that kind of a thing. So it is very essential, because if there is a comorbidity, then the prognosis changes. There is additional treatment, sometimes with medicine, sometimes with some other kind of therapies. And so the outcomes are different. Traditionally, we have been taught in clinical medicine that, try and put all the symptomatology under one heading or one diagnosis, and rather than multiple. But we have to change our track of thinking or change gears, especially when we deal with neurodevelopmental conditions. And this is very essential for the parents to understand. So you almost never see a very clean textbook kind of a picture in these conditions because of the comorbidities. It is almost like an overlap kind of a syndrome, a little bit of this, a little bit of these kind of core symptoms. So it is uh, when we deal with them commonly and we are part of the team, we realize that a symptom you kind of try to treat, the other one raises its head. So you have to kind of balance it out like a symphony, that all the conditions, the you have to kind of find out which is the primary condition, which is the comorbid, and treat the core symptoms accordingly. So with that introduction, just going very quickly through the slides, this presentation will be more on case-based videos and written content of the patient, so we can discuss the comorbid or the LD mimics very much better. So as I said that learning is almost, academics is a religion, there's a new religion in India, new secular religion in India. And we know that almost 20% of children in classroom get poor marks, and they have academic delay. They are not all learning disabled. Out of this 20%, as per my experience in this field of more than 1.5 decade, maybe 5 to 6% would qualify as specific learning disorders. So these children of academic delays are also known as underachievers, etc. So the causes for the 15% of these children with academic delays could be these, where it could be sensory because of a motor problem, sensory, hearing, etc., chronic illnesses. Language is very underrated and not much talked about, even in the neurodevelopmental field. And I would like to really emphasize on the importance of language, problem specific learning, language impairment, proficiency, also impact of psychological problem, emotional problem. And then comes neurodevelopmental problems like cognitive problems, attention problem, fine motor or DCD coordination problem, perceptual problems, specific learning disorders, and mental health conditions like anxiety or depression. Important extrinsic factors which cannot be underemphasized is environment, psychosocial, parental education background, their experiences, the kids' experience, a child's experiences with their peers, tuitions, etc. And how has he been doing? So it is a very important, intricate, and prolonged history that one has to really take in depth. So I would say learning disorders and neurodevelopmental conditions in children with academic delay, the key or the caveat is that one has to rule out these extrinsic factors before coming on to intrinsic and neurodevelopmental conditions which could hamper academic delay. So very important to, I think this is the most important slide of the entire presentation that I would emphasize. So coming to LD mimics, we said cognitive delays could be one, where the IQ is less than 85, which is the cutoff, or it could be intellectual disability. These two are very different uh, things. So even if the IQ is less than 85, you have a range from 71 to 84, which are known by teachers as slow learners, though the technical definition to them is BIF or borderline intellectual functioning. And so I have differentiated this from intellectual disability children with IQ less than 70 purely because the provisions given by the government and the presentation of both is very varied. And we will see that subsequently in the case presentation. Language is a huge issue with children with academic delays, and it could be something like English is always a second language to most of Indians, and this role of multilingualism. And we know that in a cosmopolitan society and cosmopolitan society that we live in, at least in Mumbai, a child would be knowing two, three languages for sure, and maybe can speak or understand even a fourth or fifth language. And how that impacts the academic is a very interesting uh, study. And there are a lot of studies coming now from the Southeast Asian continent. Earlier, it was more of Western world, English language, how it impacts learning and on the brain and what are the processes for it was known. But there is a lot of literature done in Southeast Asian countries and Middle Eastern countries like Africa, UAE, also to understand how language impacts learning and whether shifting onto a native language in a child who has learning problems in English language can improve the academic output. That is a very core area of research going on. Like neurodevelopmental disorders like ADHD, DCD, emotional problems, visual hearing handicaps. So you know that these could mimic as academic delays. These can also be comorbid with learning problems, almost in 40 to 50% of a child with learning disorder. So first coming to BIF or slow learners, at these children are called by the school teachers. As I said, you have this IQ or intellectual quotient continuum. So more than 85 is what is an average intelligence. Anything less than 85 is below average intelligence. And you have the zone between 70 to 85, which is known as BIF or borderline intellectual functioning. Less than 75 comes an ID or intellectual disability. We should not call intellectual disability as mental retardation. It is an ancient, archaic term now. And not only it is important for medical term, but also legal terms. As per the Supreme Court of the country, we cannot use these terminologies because these are very derogatory for the children and their families. So please note that when you have a suspicion that you do not write the word MR or mental retardation, you should write as intellectually challenged or intellectually disabled or cognitive delays. That would be a better word to frame. Right now, coming to this group of 70 to 85, so these children have very good adaptive skills, and we will go on in the next slide. You will know that intellectual disability is defined as per the new criteria, not only by the test, with or the cognitive test, but also on what is the adaptive functioning or how is the child functioning in activities of daily living. Both have to be delayed only for a child to be called as intellectually challenged. So
Just
here,
interrupting, Mona ma'am,
yes,
your slide is not visible actually.
is this visible?
No, ma'am.
Oh, I'm so sorry for this. Let me go back and okay. Should I? Is this visible now?
No, ma'am.
Okay.
Still not. Yeah.
All right. Is this visible?
Ma'am, your screen is visible, but not the PPT. Yeah.
Uh, it is showing screen sharing. Is this visible now?
Not yet, ma'am. Ma'am, your screen is visible, but not the PPT has not yet opened, I think.
Okay. So let me stop sharing.
Yes, yes.
Okay. Let's try again. Is it better?
Yes, yes, ma'am.
Okay.
Yeah.
Sorry about that. So, yeah. So let's go on to intellectual disability. So we said that there are deficits in both in the intellectual functioning, which is picked up by the cognitive test, and also in the adaptive functioning, there is delay. So what do I mean by adaptive functioning? Seven core areas of, say, bathing, dressing, etc., but also areas of uh, independent skills, right? Like, say, money concept, time concepts, then traveling across the road independently or transacting, say, doing small transactions with the uh, vendor and getting things, purchasing, say, pen, pencils, etc., whether the child understands pure money concepts, right? So, and the onset should be the developmental age. As per these are the cutoffs for the when we call them as mild, moderate, severe. Earlier it was trainable, not trainable. So these are some of the cutoffs that one should be aware. So how does one can come to a conclusion whether the child has a cognitive problem? So informally on the history, definitely. If there is a history of developmental delay, there is something, the history of an NICU stay or a birth asphyxia. On examination, you can find that these children are really little disinhibited in their behavior. They could have a smaller head size, etc. And something which is known as a draw a person test can be also done on OPD basis, where we make the child say beyond 3 or 4 years of age, and if the child is familiar with a pencil and paper, draw a person, and depending on how many parts of the person the child is able to draw, a score is given, and it is a quick measure to make out how much of delay is present and whether the child is age appropriate. Then we go on for these formal tests. These are some of the formal tests which are there. The time taken by these formal tests is amazingly long, about almost 45 minutes to 1.5 hours. So the child should be able to sit, have that kind of attention to do these tests to really come to a conclusion. So this is the draw a person test. See, this is how it looks. We ask the child to draw the best person he or she can, whether the head is present, legs are present, arms are present. And from 3 to 13 years of age, we can use this test in the OPD and give points accordingly, right? This I have adapted the slide from the IAP consensus. And again, these are some of the IQ tests which are there. They test not only the verbal skills, but also the visual, spatial, or perceptual skills. Coming to the third component, which is very challenging in a child with learning disorder, is whether there is a presence of multilingualism. And it is almost always there, as I said, uh, or whether the child is an English second language learner. ESL stands for English as a second language. So in this, we can do informal assessments for this child, what we generally do based on the history, testing, etc., evaluations, and do specific testing, which are there in almost all the 3 languages we check for the skills. We also modify the environment and translate the test in the language that the child is comfortable with, and then arrive to a conclusion whether it is a language which is causing the learning problem or whether it is a core primary learning problem. Then coming to attention problems like ADHD, we discussed it exhaustively in that previous, I think it was the third session, that whether it is attention, and we know that attention is so important for academics. It's like the tube light which should go on when a child is reading. Agar, if the child is reading in a dark or a dimly lit kind of a thing, then the child obviously will have academic problems. So it is if there is a comorbid ADHD, that ADHD itself can present like a learning problem. ADHD itself can be associated with a learning disorder, which is known as a complex ADHD, and it is very important to treat them. So I have had children where they presented with an academic delay and they were found to be severe to moderate ADHDs. And when we have seen their testing samples, pre-post medicine, it is as if it is not the same child. And this child who has been functioning at 40% capacity and with the medicine can just jump on to 70 to 80% in their academic performance. Also, if one treats the ADHD comprehensively, the parents are compliant with the medicine and with the family. So it's very important to differentiate what is ADHD, ADHD mimic, or as I said, complex ADHD, that is ADHD and learning disorder as a comorbid. So general cues is that in a child with academic problem, the attention is only when the child is doing studying or in padhai, and he has difficulties in single word reading or decoding. Whereas if it is ADHD, then he has difficulty in performing all tasks. Inconsistency is a primary key factor that we see. So they're very good with unit tests or small kind of problems or MCQs or fill in the blanks. But wherever there is a sustained mental effort required, word problems, long essays, etc., then they have a problem maintaining attention. So you don't see the specific single word reading or decoding problem which you see in learning disorder, right? And also, if you give them environmental modification, means what? If you lessen their curriculum, you give them more of single liners which they're comfortable. You put them instead of a big classroom like 1:1, so the distractions are less. The child performs much better. You give them extra time. You give them cues, it performs much better. So all that is taken in consideration when we are testing. And of course, the inattention in learning is only here it is almost activities, right? But so this is it is not very difficult in children with moderate to severe ADHD, but in children with mild inattention problem and with girls with inattention problem, it may sometimes be very difficult to differentiate between the two. Now, coming to this kind of condition, which is not much known, and known in the sense awareness, the condition is well known, the awareness among us as pediatricians, or even for that matter, developmental pediatricians and neurologists, is a little uncommon, is DCD. So if you just picture the movie Tare Zamir Par, you had this kid called Ishan who had learning disorder, and he had almost everything. He had ADHD comorbid, he was learning disorder, and he had also had DCD. So the movie begins with him not being able to catch a ball, not being able to tie his shoelaces, being very clumsy in his writing, and not being able to do craft work. So all those kind of fits in the criteria for DCD, which is a motor coordination problem and can interfere definitely with the academics and activities of daily living. This is the cue to know that this is probably a DCD. So these children have difficulty with fine as well as gross motor skill, and they have a coordination problem. And how does one diagnose it? Again, the DSM-5 or ICD-11 criteria, and we often refer them to occupational therapists who do something which is known as the BOTMP, or under do the DCD screening test. So it affects almost 5% of the school children. We don't know what is the etiology. It is often a comorbid condition coming with ADHD, learning disorders, mental health problems, behavioral thing. And as I said, it is not only the writing which is difficult, but also activities of daily living, right? And playing sports may be a challenge. And language disorders, right? So we know, like we saw this chart, that if you have a delay, and if you see the delay is present in more than two domains along with inattention, we should think of intellectual disability with ADHD. If the delay is there only in academics and there is inattention, so we think of ADHD with LD. If there is no inattention, then one should think of learning disorders. These are certain famous people with learning disorders. They from the developed world. From India, Abhishek Bachchan, and then recently I read that Bobby Deol also had a problem. Said that he's learning disabled and he reads the script in Hindi, or hears them, because that is much more easier for him rather than to read. So now let's go on to the cases. So first, we'll have this first case where you have a child with intellectual disability, and who came as a learning mimic. The primary reason being not intellectual disability. So what I will do is, I'm not sure whether this slide is visible. Is this visible? If Kuntala can help me, tell me.
No, ma'am, not yet visible. Yeah.
Okay. Okay, yeah. Yes, I think this is visible.
Not yet, ma'am.
Oh.
Your screen is visible, but I think the downloading is or opening of the PPT is taking some time.
Okay. So let me start by talking and then just let me know, or
you can try again, ma'am, by stopping share. Yeah.
Is this better?
Yes, it is visible.
Right. So this is the first case. We have 3 cases to go through. So this is the first case where this child is a 13-year-old female from a Hindi-speaking family. And please note how I've taken the case. So, generally this is not what we ask for in a medical training. We've not been taught, but, in neurodevelopmental condition, one has to be quite detailed in our history taking, because most of the diagnosis you can do on the history, right? So this is a 13-year-old female. She's from a Hindi-speaking family, class 9, and she's from CBSE board. She's the only child of the parents and from a middle socioeconomic background. Father is a dentist, doctor. Mother has studied, she's a master's in arts, and in fact, she's a school teacher. So just to underline that this is a educational background of the parents is good and they have good educational experiences. However, her birth history is significant. Full term, LSCS for fetal distress, and the child had neonatal encephalopathy, had an ICU stay of 8 days, grade 2 HIE, required oxygen support. And from the NICU, screening for vision and hearing was normal. On follow-up, neurological examination was normal, and the anti-seizure medicines were omitted at 3 to 4 months of age. So I get asked a lot as a neurologist. In fact, a couple of days back only, I've seen a baby with grade 2 HIE, that what is the future of these children? So when I see them in a neurodevelopmental setup, with or follow them up as a neurologist, I see that they may not land up with severe motor problems, but they may have some cognitive challenges. And even if they escape the cognitive challenges, they can later on have certain neurodevelopmental conditions like ADHD and autism or learning problems. And probably that is because of better survival of younger babies. Probably that is the reason why, one of the reasons that we see neurodevelopmental conditions are on the rise. So this child had delay in developmental milestones, especially language and social milestones. So her motor milestones were okay. Language, she started speaking one word with meaning at 2 years of age and sentences by 3.5 to 4 years. She also had fine motor and coordination issues. So a lot of children have quite age appropriate general motor milestones, but fine motor and coordination may be an issue. So this child required received therapy also in her younger age. At 8 years, suddenly her her seizures resurfaced. She started having multiple generalized seizure. She was diagnosed as generalized epilepsy. That point of time, her MRI revealed that she had some gliotic changes in the posterior parieto-occipital region, probably due to an HIE insult. The EEG was abnormal. She was started on 2 anti-seizure medicines like valproate and oxcarbazepine. She is well controlled and she took some time to settle it. And since the past 6 months, now she is well controlled. So as her academic difficulties were present right since preschool age group. And when she progressed to further grades, her academics started getting progressively delayed. She has difficulty understanding instruction, and therefore interacting with peers. She has absolutely, if you look at her ADL activities, she has no concept of money. She can't do mental maths and she cannot do basic monetary transactions. She's 30, but she still requires a little help of daily living and since constant supervision, right? So here you know that she's already has a delay in her ADL activities. So when we saw her in the OPD, her oral work and written work was similar. Now this is very striking in children with learning problems or learning disorders, often their oral work is better than the written work. I mean, that is like the trademark that we see in almost all children with learning disorders. She used to read word by word, she's finger tracking, and the errors are, not phonemic or they have no morpheme, means there is no word base also. It is just very bizarre. She lacks confidence. And when whatever she read, we asked her, now you tell us what you mean. So she just, couldn't comprehend what she's read. She requires repeated simplification, repetition of instruction, breaking down of the instructions, translations also. And her handwriting is already very overwriting is there, though it is legible, etc. And when we did a cognitive functioning, so already from the history with the NICU stay, delayed development, and now activities of daily living impaired, we know we are probably looking at a cognitive delay child. So her intelligence functioning did come low. She was mild intellectual disability with 54. And I, at this point, would like to share how the oral expression was, purely because this child was referred by the school only as a learning disorder. But actually, this child does not have a learning disorder. The child has a learning problem, right? So this can, so the for the school, it is all that the child has a learning problem. However, it is more that okay, sorry about this. So, however, it is that for the school, as I said, it is more that the child has a learning problem, and they almost all invariably say that it is a learning disorder or learning disability. That how it comes to us. But there are so many variants to it, right? So let's listen to this child read. You can see that she's finger tracking. She's in the 8th standard. She looks okay. So this child in the society, if you think, you would never think that she has a cognitive delay. Let please listen to how she reads.
As much as living visible and snake hundred are killed and by thought how
So
innate
you can see that these words, so she didn't know the word thousand, she substituted it by 100. She didn't know this word. She just, you know, not read this. She did not read this word. So if she doesn't read, then again, the who she substituted for how. So if she is reading like that, when you ask her something, obviously she's not going to comprehend what she's read because her reading only is impacted, right? Now listen to what she has to. Okay, I just think I'm not sure whether this thing is visible. So we go back here. All right, let us see what she has to say. This is, we are asking her what she had written, and we'll come to the written passage, or maybe we should go to the written passage first, and then we will ask her what she has. I hope this thing is visible.
No, ma'am, not yet.
Oh, it's not
Again,
visible.
yeah.
Right.
Again, I
Okay.
can, yeah.
Right. Is it seen now?
No, ma'am. Still, your screen is visible, not the PPT.
Okay.
Yes, now it's visible.
Okay. So this is what she's written. We asked her to write on my hobbies. Now remember, this is a 8th standard CBSE child, right? So listen to what she's written. My hobbies, I like to eat ice cream, play, reading, storybook. If you notice, the content is of course very, very poor quality for a 13-year-old, and it is irrelevant almost. She kind of wrote whatever she feels she knows of, and she's repeating the same words, etc. Right? And as I said, we will listen to her oral expression, which is very similar to the written expression. Again, that is what is so uncharacteristic because in learning children, as I said, they may write poorly, but orally they have lots to say, right? And even this, look at the dictation. We asked her to write internet, and she wrote Google. So we asked her to write can and getking, fun is funning. So it's absolutely bizarre. There is absolute no, um, content to it, and there is no meaning to what she has written. So we already know that this is, is not what you would expect an 8-year-old, and this is doesn't seem like a learning problem. And all this is done in the OPD. Now, whatever she can you see this video? So whatever she has written, we've asked her, now you just tell us orally.
think and enjoy in the school and I'm happy and and my mother is very happy. School
So this is the way she spoke for a 13-year-old in a CBSE medium with a good background. So you know that there is probably a cognitive challenge, which is more prominent in this child rather than a learning issue, right? So now we will go on to our second case. Let me just close this down. So the second case, this is, yeah. So this is a child with a learning language problem, and with a learning problem who presented like a, it's essentially a language problem child who presented with a learning academic delay. Is my slides visible?
No, ma'am, not yet
Okay,
visible.
all
Yeah.
right. I think there is a problem, as you said, with the slide opening, and this. I think this must be visible. I can.
Yes, yes, yes.
Okay, so we have this child, 12-year-old female. She's from a Marathi speaking background, low socioeconomic class. Both parents are, the father is a graduate, mother has studied till 12th, and now she's a homemaker. Older brother has a quite is okay, doing well in studies. Her primary language of communication at home is Marathi, and she uses Hindi to communicate with her school friend. She's not very proficient in English language. Now, typically, children with language issues, I've seen that they have a problem, difficulty picking up language, and spoken language as well as written languages. Spoken language is affected, and so the written language is affected. So she already has a difficulty understanding this language. Her birth is okay, but she had a language delay in expressive language, and that delay continued till now. She's not able to do narrative speech. That is, she doesn't come and tell exactly what is going on at home and all that. And she has academic problems since first grade. She hasn't received any phonic classes, and the school has been knowing that though she's struggling, there is some kind of counseling session going on. There is nothing else which is going on. And this poor child goes to a tuition teacher after school for almost 2 to 3 hours, and it is a small group sessions, and everybody is now at their wits end. They don't know what to do with her because despite all that, she's not doing well. So the language history, as I said, mild expressive delay. She cannot pronounce words. Currently, she's able to pronounce words okay. She's narrating, but not age appropriate. She's fluent. And other than being a myopic, there is nothing much that one sees on an examination. Again, English is reading word by word. Her fluency is decreased. She just doesn't understand what she has read. Even if one reads out the passage to her and then ask her that you tell us what you know is the comprehension, she's not able to do. Her writing is affected, math, she's finger counting. When we did her IQ test, we found out that her verbal IQ component was 76, but she's able to do her perceptual IQ is 91. So she's basically average, and she has probably after testing, we figured out she has severe LD with severe, primarily comorbid language problems that is there. So let us have a look at her video as to how she really talks, and how it can mimic language thing, right? Let me do the stop share because that's the only way it's working. There. So now let's see. This is this child reading in. I hope this is.
Daily is very nicely because
Not visible, ma'am.
they used to play football, badminton, etc., etc. And I love, I played in my friends with my brothers, um, and in medicine we go to we go to the take the rainy.
See, we asked her what you do during the rainy season, and when you ask her, she's not able to get the words. right? And she says, I don't know what is it. And even if you look at her grammar, it is a very incorrect grammar. So when we took that in Marathi, in her mother tongue, we found that she was much better with versus that. Now look at her writing expression. This is what she's written about the rainy season, etc. Now, if you notice, this is absolutely bizarre. We have new, instead of new, she's written may, then favorite, the favorite. Okay, the first two words, initial syllable, and then she just gave up. But she's speaking much better over what she has written, is what we found. And you look at the time. So we have these clocks that we draw, and we tell them, okay, now you tell us what is the time, etc. She had absolutely no concept of time. When we asked her to write in her mother tongue, she's written it much better over the English, is what we generally felt, right? And okay. And then, yeah. So that is when we thought that she probably has this. And then when we took the reading expression, we asked her to read in English to see the way she.
5, 8, 10 years. But is the map just in May to exam showed
Yeah. So, this is another word and she just doesn't know. And she is kind of, this is the errors that she's making. Instead of tales, she's just omitted that word, stories, etc. So again, and look at her finger reading. So there was definite problem there. And however, if you see her Marathi or her local language thing, she's much better in Marathi in terms of her oral expression. And that is where we thought that she definitely has more of a language.
दिवाळीला सगळे लोक फटाके आणि बॉम्बिंग फोडतात. त्याच्याने नॉईज पोल्युशन खूप होतं आणि त्याच्यामुळे पक्षी प्राणी सगळ्यांना
Yeah. So you see that what we had asked her to write about Diwali, third. Okay, so what she has written is what she's talking, right? Her oral and written expression was similar in Marathi versus the English thing. So we definitely think that she has a language problem along with the learning problem, probably. Or maybe the language problem is because of the learning, is causing the language problem, right? We'll end with today's presentation with the DCD case. I'm not sure whether this is visible. Okay, yes. Yeah. I hope this will, yes, yeah. See this? Yeah. So this is a child who's 15-year-old, Kannada speaking background, 10th standard, state board, birth history is not significant, development, everything is fine. Only academic issues noticed, and again, since preschool, right? And it's been giving retest and all that, and now they are saying that he cannot pass with retest because it's a board exam, and he uses English in the communication. Now look at the writing, right? You can almost see like a fine tremor coming, and in Devanagari script, you can see that though this is a line script, the lines are haywire. It is all in one thing. It's very difficult to read. So we also look at unlined paper, and you can see the way the formation of the letters are, and they're all joined together, and there is definitely a writing problem. So this made us suspect. We went a little more deeply in his history, and we found that he has a problem with activities of daily living. He was not, doing participating in sports. His ADLs, his tying shoelaces was affected, craft was affected, and so we did his DCD. We referred him to a occupational therapist who run their test, and they found that this child had difficulty not only reading, the speed of reading was affected, but more importantly, he had his interaction with parents was poor, but he had definitely the bilateral coordination and limb coordination, etc., was definitely affected along with visual-motor coordination. And the BOTMP test was positive for DC in this child. So this is some few of the cases. These are Not unusual cases. These are pretty regular. It's just that, you have to tease them out, and sometimes they mimic as learning problems, but actually they are not. So that is my end of presentation. I'm sorry that most of the slides couldn't open, but I think we are still hampered by technology even today's age. So if there are any questions, I'm ready to take them.
We could not find any questions, ma'am.
Yeah.
But I'm sure I'm thankful to you, Dr. Mona, for taking us through an enriching session on learning disorder mimics. I also extend my thanks to all the delegates who have participated in today's webinar. And we look forward to your participation for the upcoming webinar as well, Brainmantra. We will update you on further what will be the topic and the date as well. I also thank my medical team represented by Dr. Soumya and Dr. Shefali. And this Brainmantra series is brought to you by Zuventus, makers of BrainMax. Thank you so much, ma'am, for enlightening us. And that was really a great session.
Thank you so much. Thank you.
Thank you, ma'am.
Have a good weekend, everyone.
Yes, yes. Thank you so much.